All right, good morning, everybody. Thanks for coming. I just have one announcement. If I haven't met you before, I'm Kira Larson. I'm the Education Program Manager in the Stanford Center for Clinical Research. Welcome to the monthly Science Series lecture. So we host this lecture every month on a different topic. Next month is on the basics of nephrology. So it's titled, A Brief Overview of the Kidney, an Understated Organ That Keeps Us Balanced. So this will be on March 13th, and that flyer will be circulated most likely by the end of the week. That's all the announcements I have for now, and I'll just introduce our speaker for today. So Hans Vogel is a professor of pathology and pediatrics, and by courtesy of neurosurgery, of neurology, and of comparative medicine at the Stanford University Medical Center. He specializes in neuropathology and muscle and nerve pathology and has a current research interest in mitochondrial diseases, pediatric neuro-oncology, nerve and muscle pathology, and transgenic mouse pathology. So I'm very excited about this lecture. We have been in communication for quite some time. So please join me in welcoming Dr. Vogel. Sir. And here's
Thank you. Thank you, Kara. Yes, we've been in conversation for a while. Beginning in October, when my area of specialty, neuropathology, all of a sudden came into the limelight when I was asked to examine the brain of the shooter from Las Vegas. And I'll touch on that later. But it is an honor to speak to this group. My gratitude is only tempered by the fact that I wasn't really sure what I was supposed to talk about. So this will be a general overview of what I do as a neuropathologist. And just to set the stage for pathology in general, I wanted to take a whirlwind tour as to the history of microscopy in general. Here you can see an early pathologist examining a mammoth in an early microscope. But then much later, we have Van Leeuwenhoek, who around the turn of the 17th century devised this little instrument here in which he could, for the first time, people could see small organisms and so forth that were otherwise invisible to the naked eye. Later, we have the emergence of pathology more as we understand it now, and it really begins with Virchow, Rudolf Virchow. He held sway in Germany, and particularly at the Charité Institute in Berlin, where I've been honored to be a guest on several occasions. And this is the bust outside of the Neuropathology Institute there. And in the plaque on the ground says, in Latin, all cells only arise from pre-existing cells. And believe it or not, before about the 1850s, when the cell theory was coined by Virchow and two other colleagues, this wasn't generally appreciated. And he wrote Cellular Pathology in 1858, which is considered the root of modern pathology. Continuing the German tradition here, in neuropathology, we're all well familiar with Alzheimer, who was the first to describe the microscopic pathology in a patient that he had with what turns out to be later known as Alzheimer's disease. And here is a depiction of the finding that he described. These are neurofibrillary tangles in affected neurons in Alzheimer's disease. Later, others got on the bandwagon of neuropathology, such as neurosurgeons, because there's a long tradition which actually even continues in places like Japan, where neurosurgeons are very well versed in neuropathology. And we have two major figures in that respect, Harvey Cushing and Bailey, who in 1926 coined this. You can't really see it, but that's okay. Schematic for classifying brain tumors based on their inherent histology. In other words, they would name a brain tumor based on its non-neoplastic benign counterpart in the brain. An astrocyte tumor would be an astrocytoma, or an oligodendrocyte tumor would be an oligodendroglioma, and so forth. So they really laid the groundwork for what we still use today in classifying brain tumors. Although, as you'll see later, we're now in the molecular era, and it's perturbed this to a certain extent. Neuropathology in and of itself really came to be a little or almost 100 years ago in New York City, where the American Association of Neuropathologists was spawned. I don't think this actually has anything to do with it, but this is supposed to have occurred in 1925 in New York City. A few years later, when this was happening in New York City in 1933, they called themselves the Neuropathological Club, which to me sounds more like the description of the members of the club rather than the club itself. But later, so they changed it to the Interurban Neuropathology Club, and then in 1933 called themselves the American Association of Neuropathologists. And that is our parent organization now in the United States and Canada. We meet once a year, and it's a very robust organization, although limited in numbers. There are about 522 board-certified neuropathologists in the United States now, but probably only about 300 to 350 in active practice. They're mostly limited to academic medical centers such as Stanford and in the Bay Area. There are probably, maybe 15 board-certified neuropathologists. The number that's commonly quoted is that you need about one neuropathologist for 1 million in the population. And that matches. The United States has about 350 million people, so it's about 1 per million. I just wanted to digress a little to tell you about what it becomes to be a board-certified neuropathologist. You first have to do anatomic pathology, and in some cases combined with clinical pathology training, or anatomic pathology alone, and you have to do 2 full years of that, and then do 2 years subsequently in a neuropathology training program, such as we have here at Stanford and up at UCSF. It's the only certified subspecialty training fellowship in pathology that lasts for 2 years. All of the other ones, dermatopathology, forensic pathology, et cetera, only last 1 year. And that's because of the tremendous breadth of the subject of neuropathology. You can get into it through other routes as well, but basically the bottom line is you need 2 years of neuropath training. So we rather, in very great humility, see ourselves in the hub of all kinds of activities here. This sort of summarizes, in a way, what I do at Stanford along with my colleagues. First and foremost, I would say my primary responsibility is to correctly diagnose neurosurgical specimens from the neurosurgeons. And leading that is tumors, of course, also infections and vascular lesions. Dr. Steinberg here is a world figure in vascular neurosurgery, so we get probably more than the average number of those. We do autopsy pathology as well as surgical neuropathology, and that's quite important in many areas. You can imagine neurodegenerative diseases, infectious diseases, particularly in our immune-compromised patients, etc., and so forth. Various toxic metabolic conditions, developmental in the pediatric setting, and forensic, as I'll discuss later on. We are in the molecular era now of in pathology in general, and so we frequently characterize all of our surgical specimens and autopsy as well in molecular terms. This has tremendous prognostic and treatment implications, and it's the state of the art. if a patient comes in and has a certain brain tumor, they more often than not will go online and find out what molecular profiling needs to be done for that tumor. And so we have to keep up to speed, not only with their expectations, but with our peers and other institutions. I, as mentioned, do some comparative medicine. In other words, look at animal models of neurologic diseases. I've done that for many years. Another facet of neuropathology, but not in all locations, is peripheral nervous system and muscle biopsies. That sometimes is done by neurologists in other institutions, but here it's done by neuropathology. It's my particular passion in neuropathology, and so that's an important thing. So this is the outline for today. I wanted to go over some of the basic reasons why we get tumor or specimens, something about the acquisition process of the tissue, whether it be biopsy related or autopsy, and what exactly it is that we're looking for, and then what the ramifications of those findings would be. And as a final word, in somehow recognizing why I was invited to speak here in the first place, I wanted to touch on some examples of the Clark County, that's Las Vegas, Nevada, forensic cases as an example of what we do. So the types of tissues that we get are basically surgical or autopsy. And leading the list of surgical, and the ones that are intuitively most obvious for neuropathologists, are brain tumors. We get, I would say 500 or 600 a year here, and we can go into greater detail about those, but it's a very important part of what we do. We participate in 2 tumor boards, both an adult and pediatric tumor board, where we discuss this very actively with our colleagues in neurosurgery, neuro-oncology, neuroradiology, and radiation oncology. On the neurosurgical faculty are experts in peripheral nerve biopsies as well as muscle biopsies. So, so again, that's an important part of what we do. Basically, the bottom line is if a neurosurgeon at Stanford takes out some tissue, it's going to go to neuropathology. Even though sometimes the pathology isn't neural in nature. You could have a brain lymphoma, for instance, and we always share that with our hematopathology colleagues and so forth. But if a neurosurgeon takes out the tissue, we're going to get it. Again, I said, as for their vascular malformations that chiefly Dr. Steinberg does, neurosurgery kind of combines back surgery with orthopedists, and so whenever they do it, we get back tissues, whether they be tumors or degenerative conditions, etc. Muscle and nerve biopsies, again, are something we get. And then intermixed with many of these, particularly the brain tumors, are tissues that need to go to research. In the autopsy area, it covers all ages from perinatal and premature infants, even the very young, from terminated pregnancies, which have neurologic malformations, etc. A very important part of what we do, which I'll go into in more depth later, is neurodegenerative diseases like Alzheimer's disease. We get a steady stream of forensic specimens here, and again, research is supported by autopsy tissues in a big way. Brain biopsies are done by increasingly sophisticated methods. It's absolutely amazing how they can, with stereotactic guidance, and now we have an interoperative MRI machine and the new Lucille Packard and so forth. The surgeons can become very precise about aiming for a lesion, usually a tumor in the brain. We're usually involved in confirming that they have tissue and so forth, but what this creates for us is a big problem because they can give us a tiny piece of tissue, but it just increases the difficulty in diagnosing that with a very limited piece of tissue. It's good for the patient not to have a big open invasive procedure, but sometimes tumors are not all the same within the tumor itself, and so it creates sampling issues, et cetera, particularly when other people want tissue for research and so forth. So these small biopsies are kind of a double-edged sword. They're good for the patient, but sometimes create problems diagnostically. There is a constant imperative for saving tissues for research. We have 2 tissue banks, one run by the Cancer Center Tissue Bank and another one by Neurosurgery. And they harvest and collect tissue on a constant basis. This has its own set of problems because you obviously need informed consent from patients or their next of kin in these situations, preoperatively ideally. I personally wish that Stanford would institute consent for this as part of the admission process. It would streamline things considerably, and other institutions do that. But other peer institutions like the Brigham in Boston and others, they do that, and every single tumor at Brigham undergoes whole exome sequencing. And believe me, they will tell you that in their advertising and so forth. So it's almost a competitive situation in a public relations one that we do research on your biopsy tissue. If you were to see what we do on a daily basis as neuropathologists, the one thing that we do in which we drop literally, not literally, but figuratively what we're doing and go to the operating room is the intraoperative consultation, the so-called frozen section. That's where the surgeon wants to know what they're dealing with, either a preliminary diagnosis or simply do they have diagnostic tissue, or they want us to assist them in triaging the tissue for culture or something like that. We go down to the frozen section room, which is right next to the operating room, and process the tissue by freezing it and generating tissue sections, or just squashing it out on a slide and staining it, and we can get a diagnosis within a few minutes. This CAP, our accrediting institutions, the College of Neuropathologists, requires that this be done, I think, within 15 minutes of being called, and we comply with that with no problem. It requires, it's a very important part of how I train the fellows. They need to know that what we tell them is a matter of record on the pathology report. We can't say one thing and then, as a matter of record, have something less than that on the report. So it really requires very prompt and clear communication with the neurosurgeon. Muscle and nerve biopsies, we don't do frozen sections on them and so forth, but we do an adequacy check. We usually go to the operating room, make sure that the muscle biopsies or the nerve biopsies are adequate in size and so forth. And they do then require immediate handling. I won't go into the details, but muscles are frozen in a very precise way for frozen sections and so forth. So that's a very intensive area in neuropathology. In the autopsy area, the routine situation is that somebody expires, and if the autopsy consent allows for brain removal and examination, that's what happens. The brain is taken out, it's simply put in formalin for a couple of weeks, and so it's at least 2 to 3 weeks before we actually cut the brain and sample it for microscopy. Now that we have an Alzheimer's Disease Research Center and Stanford has a brain bank initiative, there's a big push for rapid autopsies in which we secure this tissue as soon as possible after death, but for optimal preservation of DNA and RNA and also histological integrity. This is still a work in progress for us, but we're making improvements. This references, for instance, the initiative which, thankfully for the wisdom of the powers that be at SHC, they established a brain bank at Stanford about 4 or 5 years ago, and that allowed us to successfully, among other things, get funding for an Alzheimer's Disease Research Center, which is a very prestigious thing. This is sort of a program project type thing funded by the NINDS, and there are about 20 or 22 of these around the country, and so we finally got our ADRC, and this is the staff, Ed Plowey, he's one of our neuropathologists. Tom Montine is our new chair of neuropathology, and he is a world-famous neuropathologist specializing in neurodegenerative diseases, and here's some other personnel as well. I play a pretty subsidiary role because, quite frankly, neurodegenerative diseases is not my particular forte. So what are we looking for? Well, very much similar to what other pathologists are looking for in all tissues. Neoplastic, these are sort of a crude categorization of different disease entities. Neoplastic or cancer, genetic diseases, inflammatory diseases. And these are important in the brain, whether they be demyelinating diseases like multiple sclerosis or other inflammatory conditions, vasculitis, etc. And then, very importantly, aging and degenerative diseases, infectious diseases are very important, and then a host of environmental issues, including toxic exposures, vitamin deficiencies, etc., and then trauma, of course, to the brain. Our brain tumors are categorized now according to the 2016 WHO classification. The WHO releases a new classification every 7 or 8 years, and this is done by a group of experts who get together and update the classification of brain tumors, much as they do for other regions of the body. And again, I sound like a broken record, but the molecular and genetic profiling of these brain tumors is of paramount importance these days. We are always on the lookout for brain infections. This is not only in the context of the living patient, but also in autopsies and so forth. And some of these represent important public health issues, whether they be viral infections or others. Muscle and nerve biopsies cover a wide gamut of diseases. Inflammatory diseases like your polymyositis or dermatomyositis, etc., various hereditary diseases, muscular dystrophies, etc., and then importantly toxic and metabolic other diseases as well, sometimes related to drug exposure, etc. And autopsy considerations basically, as I said, are A to Z. There are many, many considerations there. Perhaps more importantly than, with all due respect, the kidney, what was the phrase that they used for the kidney? Underappreciated or an organ? Understated, yeah. Yeah, we call them lesser organs, okay? Anyway, although the kidney is very important for mental health. Anyway, but perhaps to a higher degree than pathology of other tissues, gross pathology, in other words, what you can see with the naked eye, is very important in neuropathology. And quite often, that'll yield a diagnosis right there. You don't need a microscope in many situations once you recognize something to the naked eye. Our surrogate for that is neuroradiology. And it's certainly a truism that I impart to my fellows that if you don't know what the radiologic appearance is of, for instance, a tumor or some other process, you will make a mistake eventually unless you acknowledge in the report specifically that you don't know what the neuroradiologic appearance is. But this, again, can sometimes yield a diagnosis. You don't even need a microscope in certain situations, or even tissue. There are very stereotypic patterns of atrophy in neurodegenerative diseases, for instance, which trained neuropathologists can recognize. And once you make a presumptive diagnosis on a gross basis, whether it be surgical or autopsy or radiologic, this provides a rationale for sampling for microscopy. This is how neuropathologists don't tend to engage in neuroanatomical descriptions to the elegant state of neuroradiologists. They are very adept at honing in on certain structures and so forth, but we kind of crudely divide the brain into these segments. There's the tentorium, which is a leaf of the thick covering of the brain called the dura that separates the cerebellum and the brainstem from the part above it. So we call this the supratentorial part of the brain, the hemispheres, etc. We are interested in the coverings of the brain, whether it be the dura mater or even the skull itself, or the vertebral bodies. So those are some important categories. The cellar region here, where the pituitary gland lives, has its own set of pathologies, not to mention of the pituitary itself, but there are other tumors that can arise there. And then the so-called supracellar region, and it's a very high real estate area because the optic pathways are passing here. The hypothalamus, which controls so many basic functions, is right there. So this is an important region within the brain neuropathologically. We have this tiny area here, the pineal gland, thought to previously be the seat of the soul, but we now know it's more like the seat of certain types of tumors and so forth. Here's the brainstem, the three parts, the midbrain, the pons, and the medulla, and we know that certain tumors arise typically from certain areas. And then there's the spinal cord, of course, and then way down at the bottom of the spinal cord is the so-called cauda equina. It's a bunch of nerve roots, spinal nerve roots, and that gives rise to certain tumors and so forth. So these are the compartments that we recognize in the brain. Within that, of course, are the ventricular spaces, which hold cerebrospinal fluid, which is constantly flowing through the ventricles down around the spinal cord and then being reabsorbed into the bloodstream over the convexities. So this would be just the normal lateral view of the brain. This is the front here, the eyes, and so it would be here. You can barely see the olfactory bulbs here, which are the cranial nerves for smell. Here's the temporal lobe, the occipital lobe, the parietal lobe, and frontal lobes. And here would be a fairly typical gross diagnosis. Not that we're not going to subject this to microscopy, but you can see there's diffuse atrophy here. You can see down into these sulci, and the gyri here are narrowed. And so this is diffuse cerebral atrophy. Sometimes there's a bit of sparing in Alzheimer's disease for the occipital lobes back there. This would be, by contrast, another neurodegenerative disease in which you see a completely different pattern of atrophy. Here, the frontal lobe here is very selectively atrophic. I mean, you could draw a line here between the part that's relatively normal and this so-called knife edge atrophy, severe cortical atrophy. It's also involving the temporal lobe as well. And this is a so-called frontotemporal lobar degeneration. It's a good example of Pick's disease. Here's an example in the cauda equina that I just mentioned at the end of the spinal cord with a bunch of spinal roots coming off in the normal setting here. And you can see these roots here are very shrunken and atrophic. And that's in a case of amyotrophic lateral sclerosis or Lou Gehrig's disease, in which motor neurons are lost. Now, this is one of the most basic aspects of neuropathology. It's an attribute of all pathologic processes, but it's, again, raised to a level of extreme importance throughout neuropathology, and that is the doctrine of selective vulnerability. Again, if you take the liver, for instance, certain toxins or pathologic processes will affect certain parts of the liver differentially. Okay? But in the brain, where it's divided into such different areas with different functions, this becomes very, very important. And the principle of selective vulnerability means that cells and regions of the brain are selectively vulnerable to injury of all sorts. And they're, in a broader sense, they're predisposed to certain pathologic processes, whether it be tumors or infections, et cetera. And here's some examples. In vitamin deficiencies, thiamine deficiencies, which is a problem that, for instance, chronic alcoholics face or others with malnutrition, selectively involves what's called the mammillary bodies. They're small structures at the base of the brain. And this produces a very distinctive neurologic syndrome called Wernicke-Korsakoff syndrome. In the toxic metabolic category, carbon monoxide poisoning hits the globus pallidus. It's because carbon monoxide likes to bind iron containing proteins like hemoglobin. That's why it's so toxic. But this region of the brain has the most iron in it, so carbon monoxide is very toxic to this region. Methanol toxicity. Methanol is a contaminant of sort of bathtub liquor, moonshine liquor, and so forth. It's also common component of solvents like windshield wiping fluid and all that, and homeless or alcoholics or something will sometimes ingest this and create a problem in the brain centered on the putamen and also visual pathways. Ethanol affects the cerebellum. Sometimes chronic alcoholics will have an unsteady gait from cerebellar damage. Radiation tends to affect white matter because this is a very metabolically active part of the brain, and radiation is very toxic to the most metabolically active areas that undergoing turnover. That's why it's useful for tumors. Mercury is exquisitely toxic to the cerebellum in your posterior fossa. MPTP was a mishap in designer drug and hits the substantia nigra, so it creates a Parkinson disease-like syndrome. Various infections selectively involve different areas of the brain. Inborn areas of metabolism, depending on what type of cell is most effective, will affect different parts of the brain. And then we know, as I've already depicted, that neurodegenerative diseases can affect different areas of the brain selectively. Even hypoxia ischemia, if you have a heart attack or for some reason the brain is deprived of blood supply, different parts of the brain will suffer more than others. So another way to divide the brain, aside from those compartments that I described earlier, and this is a coronal section right down the middle here. You can see the ventricles. This is white matter, and this is gray matter. So that's often our simplest but very salient description of compartments of the brain is gray versus white matter. And here's an example, for instance, of radiation toxicity. You can see if you agree with me here that the white matter here is very much injured, whereas this gray matter, this ribbon that covers the brain like that, is relatively immune. So here's a good example of selective vulnerability. I'll just digress a little to say that this is actually not an infrequent reason for us to be called to the frozen section room by the neurosurgeons, because patients will have radiation therapy for generally a tumor, and then some of them, for unknown reasons, develop swelling to a greater extent than others, and they don't know, the neurosurgeon or the neuroradiologist doesn't really know if it's a tumor that's recurred or if it's a swelling just from radiation therapy, or sometimes both. So they'll go in and give us a piece of this and ask us to look for tumor versus radiation necrosis, and they have to resect it anyway because it creates a mass effect, which is very bad in your skull cavity. Here's another example of a selective white matter disease. This sort of granular appearance affecting multiple loci within white matter. This is an example of an infection called, and the disease is called progressive multifocal leukoencephalopathy. This is because the JC virus likes to infect oligodendrocytes, and oligodendrocytes are the cells which make white matter, which make myelin in white matter. So they're more plentiful in that area. This is kind of the scourge of people who are immunocompromised. We all have JC virus in our brains, but when you become immunocompromised, sometimes it's reactivated and goes out and infects oligodendrocytes and creates this, this lethal condition. Here's an example, as I mentioned, of methanol toxicity. You can see it's exquisitely toxic to this part of the brain called the putamen and also the caudate. As contrasted here, for instance, well, it's not, you can't see it there, but the carbon monoxide poisoning, putamen is just fine, but it's hit the globus pallidus here. So now into brain tumors, and what are we looking for there? Again, we deploy the 2016 WHO classification, and this is front cover from last year or 2 years ago. And this is the basic, these are all your choices of brain tumors here. There are about 128 of them. The ones that you tend to think of when you think of a brain tumor, like glioblastoma or something like that, are tumors of neuroepithelial tissue. These are innate or tumors arising in brain tissue. Sometimes you get tumors of the cranial nerves coming off of the base of the brain and the brain stem, or paraspinal nerves. Meningiomas are the second most common tumors, and they arise in the coverings of the brain. Then there are a host of other ones, melanocytic tumors, lymphomas, as I mentioned, germ cell tumors, etc. The most common single category overall in adult brain tumors are actually metastatic tumors. You know, your metastatic lung, breast, whatever. They comprise the largest single group of brain tumors. And this just is an example. I think I've hopefully taken out all the HIP identifiers, but this would be a classic format of one of our surgical pathology reports. Actually, we'll start over here. There's more over here which I omitted, which has to do with the gross description of the specimen and all that. But you can see over here, within our report, as a matter of record, in the medical record, is our frozen section diagnosis. This is what we were called down to the operating room to do. Tumor, right frontal, malignant glioma, and then these are the people who made the diagnosis here. After we look at it under the microscope, we render a description. Some places do that more than others, but we tend to give a brief description, and then we describe the results of special molecular testing in the form of immunohistochemistry. Here, I'm not going to go into any detail, but we yield this sort of WHO-sanctioned diagnosis here. You list the location, biopsy, glioblastoma, and this is a tremendous now prognostic importance, whether it's IDH mutant or not, and this one, luckily for this patient, is mutant, and it's a WHO grade 4. That WHO has 4 grades, so it is the highest grade tumor, and glioblastoma is the most common primary brain tumor in adults. So anyway, that's what we have. We also have the opportunity of doing other molecular testing. MGMT promoter methylation will dictate the response to chemotherapy and so forth. But this is just one example of what what a contemporary diagnosis of the brain tumor looks like. Infections are important too, and as I said, sometimes it reflects a genuine public health issue. Many of you recall that in Disneyland in December 2014 there was an exposure to measles, and behind this benign setting here was an outbreak which eventually spread to many, many states, and this is not only poses a risk to people who get the measles, and in the rare case it could be extremely complicated, but it predisposes these individuals, particularly very young children who are pre-immunization, to a disease called subacute sclerosing panencephalitis. You don't have to be immunocompromised. It's immunocompetent individuals, which occurs years after the initial infection by measles virus. So we're going to see a bump in the incidence of this, albeit rare disease, thanks to this measles outbreak. It could be anywhere from a few years to up to 20 years later. We're going to see the incidence of SSPE. Risk is especially high in patients, like I said, who contract measles during the first year of life. It's significantly reduced by measles vaccination. It's basically due to a defective measles virus, and under the microscope we would recognize these viral inclusions like that. Okay, not to belabor this, which is I'm tempted to do because this is my particular passion in muscle and neuropathology, but there are a bunch of things that we look at. We get probably about 150 in-house nerve and muscle biopsies a year. We get about double that amount of consult muscle biopsies. Sacrificing all modesty, will say I think we have the best nerve muscle pathology lab in the West Coast. We get biopsies from all over California, particularly the Bay Area, but also Alaska and Hawaii and so forth. So we have a great muscle lab, and we don't do this in a vacuum. In terms of the local team, that would be the Stanford Neuromuscular Disorders Program team. This is a group in neurology headed up by Dr. Day, and their expertise is considerable. They're not only very expert in diagnosing routine neuromuscular disease, but Dr. Day has spearheaded a lot of treatment protocols for spinal muscular atrophy and other muscular dystrophies and so forth. So I just wanted to put in a plug for them. So after we've done our diagnosis and all those different categories, what is the implication? For obviously tumors is a great example. Our diagnosis is of incredible importance into how they treat that patient. In some cases, it's just a watch and wait situation after we make a diagnosis. Other situations require full bore therapy, chemo, radiation therapy, etc. Our diagnosis may imply certain antibiotic therapies as well, depending on if it's an infectious diagnosis. The prognosis hinges very much on our molecular diagnosis. And again, that if the neuro-oncologist doesn't tell them that, they'll find it online before they do. In many situations, now that we're in the molecular and genetic era, there are important ramifications for genetic counseling as well. You can imagine muscular dystrophies or even hereditary tumor syndromes, etc. Banking, again, is very important. It is the absolute commodity of research, of human research, is banked tissue. And so we strive to do our absolute best in banking tissue. It's not just necessarily freezing a hunk of brain tissue. Sometimes it means harvesting DNA from the patient. Sometimes it means getting tissue or DNA from family members as well. All this has to be done under strict oversight by the IRB and as informed consent and all that, but this is a very active process here at Stanford and other institutions. And of course, we are a medical school, and I have a neuropathology fellowship in which, like I told you, it lasts for 2 years, but it's staggered. We have a new fellow each year. So I'll have at given time a first year and a second year fellow. And they need to understand all these things as well. But I also teach neurology residents, neurosurgery residents, regular anatomic pathology residents who won't necessarily go into neuropathology, but they need to know about it and so forth, and the medical students as well. So I wanted to now focus on an aspect of my job which is not reflected in all academic neuropathology programs. Many of them, not by any means to their discredit, but they shy away from forensic neuropathology because of the legal entanglements. They don't want to be dragged off to court, which is actually something I do very rarely as a facet of this. But they may be immersed in their own research effort, et cetera. So not all academic institutions do forensic neuropathology, but I very proudly do so. It's been a fountain of very rich teaching material for my fellowship. And in another important way, I feel like it adds academic weight to what's happening out there in the community. Medical examiners are not well funded in some areas. They're kind of constantly overwhelmed by just routine stuff, and they very much like to have an expert in the field to ship that specimen as fast as they can get it out of the door for an expert diagnosis. It does in the criminal setting. It is important to be on firm footing, so that prosecution, if it's appropriate in certain situations, be based on sound evidence. And again, that's an important facet of an academic institution in supporting the community medical examiner. These are the categories of death. There's a bit of a digression here, recognized in forensic pathology, not just neuropathology, but forensic pathology. And they are natural death. That includes infections or neurodegenerative diseases in the neuropathology area, cancer, cardiovascular, et cetera. So any natural death is one of the categories. Homicide is another one, and that includes pediatric and adult. The very poignant situation for neuropathologists are the shaken baby cases in the pediatric arena as well. But we get a host of adult homicides as well. The forensic pathologist out there in the community doesn't need us for a gunshot wound to the head necessarily, but in other tricky situations that involve the timing of an assault or something like that, they may call upon us and send us the brain. Accidental is another completely different category, and then lastly is suicide. So those are your 4 choices when you're signing out a forensic autopsy. So I'll give you some examples down the list here that I've had over the years. One is West Nile viral neuroinvasive disease. And this actually first came to the attention of the medical community through forensic pathologists. Not neuropathologists necessarily, but remember West Nile was thought to be transported from the Middle East on an airline flight with an infected mosquito in New Jersey, I believe, some years ago. And then it spread across the country. So now you see that California and some of these other states have the highest incidence of West Nile virus neuroinvasive disease. And this is in terms of numbers per 100,000 population. All West Nile virus disease doesn't involve the brain. You can see that it's a relatively rare occurrence, but when it does happen, it has severe consequences in the brain. It creates different syndromes. One is a frankencephalitis, a viral encephalitis, and sometimes that can affect the substantia nigra so that a person has a lingering Parkinson disease-like syndrome from West Nile virus. That can create meningitis as well, and also an acute flaccid paralysis. The West Nile virus likes to infect the motor neurons of the spinal cord very much like polio in years past, and so it creates a polio-like illness. So all these are severe consequences of West Nile virus. Because of its predilection for spinal cord involvement, this was missed for a number of years because the original pathologic examinations in a forensic setting in New York and New Jersey does not routinely involve the spinal cord. In fact, sometimes a routine examination in a medical examiner setting only takes the brain above the tentorium out because that's the easiest part to get out. But it wasn't until they started taking the spinal cords out in these forensic settings that they recognized that that was very much part of the spectrum of infection in West Nile virus neuroinvasive disease. So again, we get a lot of these. This is the classic kind of situation where a medical examiner is not going to be really equipped to diagnose the subtleties between Alzheimer's disease or Lewy body disease or frontotemporal lobar degenerations and so forth. So they, again, get this out to an expert as fast as they can. So what's the importance of that? Well, they could just say senile dementia or something like that. Sometimes a family wants to know if it's a heritable condition. I was approached, for instance, by the daughter of a gentleman who passed away 2 or 3 years ago, and she very much wanted to know if he had Alzheimer's disease in her own interest and the rest of her siblings. She asked the Santa Clara County Medical Examiner to do the study. They're kind of chronically overwhelmed, so they said, well, we will take the brain out, but we're going to send it straight to Stanford. And everybody was fine with that. So there are issues about the heritability of certain neurodegenerative diseases. Another important one is the question of elder abuse. And this is actually sadly not uncommon issue in the brains that I get from Las Vegas. In other words, is this person who is maybe chronically debilitated truly demented, or are they just unable to care for themselves for some physical reason and then subject to elder abuse, or while it's no excuse for this, are they genuinely demented on the basis of Alzheimer's disease or something like that? So this is a not uncommon issue here. We see cancer and cardiovascular disease and all the routine common causes of death as well in the natural category. Here's an example of a tumor that was disclosed after examination of the brain of a 5-year-old from the Central Valley. He came in to the emergency room with several weeks of severe vomiting and so forth, but basically arrested in the emergency room and couldn't be resuscitated. So they sent us the brain. And back here in the posterior fossa at the back of the brain, you can see the cerebellum here. This is actually the brain stem here, or what's being very much compressed over by this tumor arising in the fourth ventricle. And this is the classic appearance of an ependymoma. It's a fairly common childhood brain tumor. Sadly, when you have a mass lesion in the posterior fossa, it can result in that type of symptomatology with worsening vomiting and so forth, partly because of obstruction of CSF flow. They'll get hydrocephalus and all that. It's very much a surgically curable disease, but this child went to death with an undiagnosed ependymoma. This is another interesting situation. This was a real case from Las Vegas. This was a 40-year-old, bedridden, paralyzed, nonverbal male. He had a seizure disorder, and he had a brain tumor. They couldn't tell us exactly what kind of brain tumor it was, but he had received chemotherapy and radiation, and then was kind of written off to be given 1 year of life to live. So he lived at home, as I say, in a bedridden state like this. He had not been seen by a doctor for 2 years. Wife basically found him one day moribund, and he expired. So this is a cross-section of the middle part of your brainstem called the pons. And if you look under the microscope in an area like this, this is what the neurons look like. I don't have a normal for comparison, but this glassy kind of hollowed out appearance is something we call chromatolysis. And in this setting, it's highly suggestive of a certain vitamin deficiency, which this guy probably had. It's called niacin deficiency. The disease is called pellagra. It's actually something that was seen quite commonly in the deep south of the United States, where they depended on corn as a main staple in their diet. But it's also seen in various chronic debilitating diseases, in mixed vitamin deficiencies, and also in alcoholics. It creates dermatitis, diarrhea, and dementia. And there's this term here, the neuronal chromatolysis, where you see in various neurons throughout the brain. So this is chromatolysis and niacin deficiency, and again, this is what it looked like in our patient. So there's kind of a fringe benefit to sending us a brain like this in a forensic setting, and that we can make an interesting diagnosis like this of a vitamin deficiency. Now this is an especially poignant situation. This also probably falls under the category of a natural death, although for reasons I'll explain, it was actually put into the homicide category. This was a Las Vegas case of a 14-year-old male. He had severe cognitive delay, emaciation, he was bedridden, and he carried the diagnosis of a condition called Dandy-Walker malformation from hospitalization at 1 month of age for an RSV infection. This child, as the autopsy revealed, died from a volvulus of the intestine. He probably became septic from that and died. So it wasn't strictly from his neurological condition, but he was very severely cognitively delayed. He was on tube feeds, et cetera. And so this is what he actually had when I looked at the brain. It was not, here, let me go up. It was not the Dandy-Walker malformation. This is something where the posterior part of the brain is occupied by a very large cyst, and without belaboring it, many of these children can go several years without even diagnosing. It doesn't, in and of itself, produce a cognitive deficiency. So the mother of this poor child was laboring under the false impression that he had a severe neurologic impairment related to a disease that in fact doesn't really cause much of a problem. Some of these kids will get a shunt, et cetera. Sometimes they're associated with some other malformations and so forth, but basically Dandy-Walker malformation is a pretty benign condition. What he had was this. You can see there is a cleft in the middle of the cerebellum with glancing similarity to Dandy-Walker malformation, but this is called Joubert syndrome. And this is a hereditary condition affecting cerebellar development that then would explain his severe condition. And what makes this especially poignant is because he was so emaciated that the mother was charged with murder in this situation. And, but I think it's, again, I don't know what the outcome of this case is. The scene would certainly have argued against her being negligent. Apparently she surrounded the child in his room with colorful toys and things like that. It's a very poignant situation. But anyway, with this perspective of having this severe neurological malformation, I would hope that she would, in a sense, be forgiven. Homicide, as I mentioned, is an aspect of the tissue, the things we get, and probably the most, the saddest aspect of that is the so-called shaken baby syndrome, or non-accidental head injury in children. Now, this is something as health providers we all need to know about, because certainly in the emergency room setting and others, if you even suspect this is going on, you're obligated by law to report it. It's the most common cause of death, meaning head injury, from child abuse. It's quite specific to infancy, again, very sadly. And children in this age group, under a year of age, have anatomic features whereby they have a relatively large head as compared to the body size. They have very poor neck control, as you all know. So when they're shaken, the head will whip back and forth, and there'll be shear forces that affect the intracranial contents. It's now thought that part of the syndrome of shaken baby sequelae is actually a rupture of the upper spinal roots that result in a cessation of breathing and so forth from loss of nerve supply to the diaphragm. 25% of them who are clinically diagnosed with this die, and 80% of the remaining have very severe lifelong neurologic problems. About 60% of them are male. Definitely poverty and low socioeconomic status is a risk factor, but it's by no means limited to that group. Some other risk factors are history of abuse, domestic violence, low socioeconomic status, like I said, perinatal illness. A lot of these kids are chronically ill or born premature, something like that. They may be subject to incessant crying and family dysfunction. The perpetrators are male in 65 to 90% of cases, and in descending order of frequency, the fathers, the boyfriends, and then female babysitters and mothers. Moving into the adult homicide category, this is another Las Vegas case of a 25-year-old man with a history of head trauma 3 years prior to death, subject from assault. He had had subsequent headaches of increasing severity, and he was discovered dead with no apparent signs of recent head trauma. I beg your pardon, this is not actually a bona fide homicide case, but it involved assault previously. Anyway, he was discovered dead, and presumably from a opiate overdose. And we all know we're in the opioid overdose epidemic, and he had a mixed drug profile, but an opioid was in there. The general postmortem exam showed obesity and hypertension. When I got the brain, I was asked to look for evidence of axonal injury. Diffuse axonal injury is something that happens in severe blunt head trauma where white matter tracts are sheared. If you get T-boned out there and you're whipped around and your brain hemispheres do this, the corpus callosum holding the two hemispheres together will undergo shear injury. Other areas of the brain are subject to that as well, but this would be a classic area for me to look for these microscopically. Sometimes you don't see anything to the naked eye. And lo and behold, and the people in Las Vegas have a very low threshold for asking me to do this sort of exam when there's any slight suspicion of assault or something like that. And we have a very, I won't belabor you with the details, but we have a very, very sensitive way of showing axonal injury, and that's by beta amyloid precursor protein immunohistochemistry. And so we can see in this positive reaction here some of the snapped axons and so forth that have been torn and sheared through diffuse axonal injury. The only problem in this situation is that this guy had not been subject to head trauma. He simply underwent a drug overdose, a fatal drug overdose. But we found these all over the place through his corpus callosum. In other white matter areas as well, which are not traditionally thought to be subject to shearing injury. And it raised the issue, is there something about opiate overdoses that causes an interruption in axoplasmic flow, in other words, the flow along axons of molecules and so forth. And in fact, this is touched upon in some of the forensic literature where this was described mostly out of Germany in opiate overdoses, where they showed evidence of diffuse axonal injury without a history of head trauma. And so I became keenly interested in this, and I wanted to see if this was a more pervasive aspect to opiate overdoses. It could provide, for instance, a substrate. I'm not sure it's a treatable condition, but part of the explanation for death or disability after opiate overdose. Well, you'd think that with the opioid epidemic, it would be easy to get these. Not true. I listened to NPR, they're talking about the epidemic in the West Virginia area. I know a forensic pathologist there. I said, can you send me some of the brain tissue? He said, brain tissue, we don't even open the body in these cases. We just do a drug screen and that's it. We're completely overwhelmed by this process, much less taking their brain out, much less sending you some of their brain. But Las Vegas, where I have an excellent working relationship, they were very hesitant to do this because a medical examiner can get in deep trouble by being revealed publicly that any of the tissue derived from their autopsies is going for research, and with good reason, I think. So at long last, after they worked with their legal department and so forth, they came up with a consent form from their next of kin to allow me to do this. And now I do have a collection of specimens, and I have made this observation in a number of them. So hopefully this will eventually be publishable. I just wanted to touch on another very current topic of interest, and that's chronic traumatic encephalopathy, most well known now from sports injuries. But it's seen in a number of other situations. In the interest of time, I won't go into this, but this is an increasing a reason for me to get these forensic brains is to examine them for chronic and traumatic encephalopathy. This is just an example from a case of a baseball player, and he has some of the stereotypic lesions of chromatic encephalopathy, CTE, is revealed here by abnormal tau deposition and so forth. And here's the bullet tract from where he committed suicide. And the last manner of death is suicide. And probably, as I touched on earlier, the most notorious case that I have been involved with was the one I mentioned earlier. Back in October, I was actually on a speaking engagement in Europe, and in an airport hotel in Lithuania, I got a call at about 2 a.m. there from one of the forensic pathologists I work with frequently in Las Vegas saying, the coroner wants to speak with you because he wants you to do the shooter's brain from Las Vegas. And interestingly, they know why he died. He shot himself in the brain through the mouth, but they were besieged by people out in the community and other well-meaning people who say, you need to make sure that he doesn't have Lyme disease or certain other esoteric diseases, vitamin deficiency, drug effects, and so forth. So they said, we're sending it to our guy at Stanford. So this was out in the New York Times and created quite a publicity storm. I did get the brain. It was hand-delivered to me by Mr. Freudenberg, the coroner, and I did issue a report. And as of a week ago, I don't think I could have said anything about it for obvious reasons. This is HIPAA-protected information and PHI and all that. But at the end of last week, everything came out. It was a result of a court order. The local news media had sued the coroner for release of that information. So yesterday I was actually quite amazed. If you go to Google News, there's something called Document Cloud, and I clicked on it, and there's the entire autopsy report with toxicology, with my report, everything, every word of it. And but the bottom line is, and this summarizes what my diagnosis was in the case. Again, he had the gunshot wound to the head and all the consequences of that, but the trajectory left much of the brain intact for me to look at. And I found mostly what you would expect in a 64-year-old with atherosclerosis. He had some hypertensive changes and atherosclerosis. He had kind of a teaser finding, which was an abundant number of these corpora amylacia. These are little globules that are found around the coverings of the brain and so forth. And we just know as neuropathologists that the occasional older adult has a bunch of these in their brain. We don't really know. They are somewhat disease associated. You can see them more frequently in Alzheimer's disease and so forth. But I exhaustively examined this brain for any of those disease processes and didn't find anything like that. So it's just an unknown finding. It's a finding of unknown significance in this brain. Some people think that corpora amylacia are sort of a wastebasket, a waste compartmentalization mechanism in the brain, so it raises the possibility if he had some toxins or something like that, but I'll leave that for others to speculate. Okay, any questions, comments? Yeah. Yeah, just I'll revise that slightly. What you're thinking of is Parkinson's disease. Parkinson's disease. There are, by the way, well-known examples of combined Parkinson and Alzheimer's disease, but what you're talking about is pallor and loss of pigmented neurons in the substantia nigra in the brainstem. I don't know if I had a picture of that earlier. And that's because of the selective loss of those pigments, which is not actually, this is getting very nitpicky, it's not melanin, it's called neuromelanin, which is different than melanin that's responsible for hair color or skin color and so forth. So yeah, that's true. What? Why? It's thought, well, that's a good question. These cells are chiefly involved in dopaminergic transport. Dopamine is a neurotransmitter which has its own sort of double-edged sword. It's a very toxic molecule, actually. And when these neurons, for whatever reason, it may be mitochondrial-derived oxygen-derived free radicals in them, or abnormalities of synuclein, which is a molecule that is involved in the packaging of dopamine. When there are defects in that, it becomes a vicious cycle where dopamine probably is sort of toxic to those neurons themselves that make dopamine. Yeah. Things like this. What? Yeah, I mean, this would be an example, for instance, as compared with normal, of a pattern of atrophy that is highly suggestive of this disease. But then we would this is not a radiographic image. This would, by the way, be revealed by radiology. A skilled neuroradiologist would be able to figure this out in life. But then it dictates our strategy. For instance, I'm going to be taking a section of this and probably a section of this for comparison and everything to look at under the microscope. Yeah. There are a host of appearances for cysticercosis in the brain. The classic one is just the little, they're little cysts. They look about the size of a pea. It's a little cystic space, and the little worm will be right in the middle. And very interesting, and for those of you who don't know it, you probably already do, that this is from improper hygiene and so forth that involve a tapeworm egg that then ends up in your body and the brain. Huh? Pigs are an intermediate host, that's right. But this is a rather, I don't know, it's sort of an unpleasant thing, but most of these infections are from auto-infection, is poor hand hygiene, not directly from pig meat. There was a famous example of cerebral cysticercosis in Orthodox Jews in New York who don't eat pig, obviously, but they traced the exposure to the cysticercosis eggs, the tapeworm eggs, under the fingernails of their housekeepers from Latin America. Anyway, so there are a number of appearances. You can see a bunch of these as little cysts in the brain, or they can be in the surface of the brain, or sometimes they are in the, well, sometimes they will get into the ventricular space. And I had a situation where I was called for a frozen section. The neurosurgeon, if the little cyst and the parasite in its cyst starts traveling down here, all of a sudden it gets stuck right here. It happens sometimes. And then there's acute hydrocephalus, a backup of CSF. And so they were pulling, the surgeon was in there pulling them out and giving them to me. So there are a number of appearances. It's a very interesting disease in the sense that the live parasite in its little cyst usually doesn't cause a problem. It's because they fend off, and they have a way of fending off inflammation. And it creates kind of a neutral standoff. But the minute they die, all of a sudden there's a tremendous inflammatory response, and you get seizures and everything. Yeah.
Can you give an estimate of the number of cells or volume of a biopsy?
Oh, the stereotactic biopsy that we get is from a wide bore needle, you know, that goes in there. is about the size of a grain of rice or something. If I had put it in common terms, it's probably 2 millimeters by 1 millimeter. In terms of cell number, your guess is as good as mine. Don't know. Hey. Yeah. No, once let's say and I didn't mention this, but this came dangerously close. I actually, you're all sitting down, I have 3 very young children. And we had taken our, at that time, 12-month-old and his 2-year-old sister down to Disneyland. And we missed this exposure by 2 days. But if he had if he or the people who got measles from this exposure, the measles is there. There's nothing in your brain and so forth. There's nothing you can do at that point. What happens is through a little genetic twist, it becomes a defective measles virus that can't kill the cell, but it's able to propagate and then spread from cell to cell. So that's the basis for this disease. And happily, that only happens very, very rarely for the people that get measles. But there will be a bump in SSPE. Okay, thank you.